Welcome to the Diabetes Foundation webinar, COVID-19, Facts and Myths You Need to Know. Our webinar today is in collaboration with BioReference Laboratories. All attendees are in listen-only mode. If you have questions throughout the presentation, please feel free to use the Q&A button in Zoom, and we will get to questions at the end of the presentation. Now, it is my pleasure to introduce to you the Executive Director of the Diabetes Foundation, Janine Salente. Janine?
Thank you very much, Jim. Dr. Mathur, if you can just go to the next screen, please. Thank you all so much for being here today. My name is Janine Salente, and I'm the Executive Director at the Diabetes Foundation, and I will be your host for today. I'm going to begin by briefly describing the work of the Foundation before I turn the webinar over to Dr. Mathur to present. We will be doing a question and answer at the end. Throughout the webinar, if you have a question, please write it in the Q&A icon at the bottom of your screen. I'll collect them throughout the webinar and answer them at the end. It is, again, thank you so much for being with us today. It is our pleasure to partner with BioReference to bring today's webinar to you, COVID-19 Facts and Myths You Need to Know. Dr. Mathur, if you can go to the next screen, please. For the past 30 years, the Diabetes Foundation has been helping people from Bergen County through Cape May to manage their diabetes. We work throughout the state and provide free insulin, diabetes supplies, A1C testing with thanks to BioReference, transportation assistance, and educational programming to help people with diabetes prevention and management. Our agency is the only one of its kind in the state of New Jersey and beyond, and we help thousands of people and their families each year. We serve more than 1,000 people per month, actually, with our webinars, our Facebook Live yoga and low impact exercise programs, and our diabetes care videos. COVID-19 has added additional concerns for those with diabetes, and for the last 6 months, there's been an abundance of information about COVID-19's impact on those with diabetes. And that's why today we asked Dr. Mohit Mathur to be here to help us decipher between the truths and myths of COVID-19, to allow us to support our healthcare today and throughout this pandemic. Dr. Mathur is the Vice President of Medical Affairs at BioReference Laboratories. He holds an MD and a Ph.D. in Biochemistry and Molecular Biology. And since he joined the firm, he's been involved in outreach to physicians, government agencies, and patients about the importance of advanced diagnostic testing. Since the outbreak of the COVID-19 pandemic, Dr. Mathur has provided clinical and technical expertise regarding COVID testing to BioReference's partners. And he's additionally coordinated discussions between BioReference and the FDA and the CDC. BioReference Laboratories is one of the largest providers of COVID-19 testing in the world. And we are thrilled that Dr. Mathur agreed to bring his expertise to the Diabetes Foundation's participants today to help us live the healthiest life we can. So Dr. Mathur, I'd like to turn the presentation over to you.
Thank you so much, Janine, for that kind introduction and for extending this invitation. It's a pleasure to speak to your members and about this topic, which has taken over a great deal of our lives, our country's life, and has changed things throughout the world. So I'm just going to lay out a little bit of a foundation of what I'd like to do today. It's been 5-6 months now since this has all started. There's been a lot of information that's come out. There's been a lot of changing information that seems to happen almost every day. This is a disease which has received all of our focus from the medical community, the patient community, governments. And so there's just a lot of information overflow in a way that's coming out to everyone. And it can be hard to keep up sometimes and understand, where we are today. And that's not only true of lay people, it's true of physicians, it's true of health authorities, it's true for healthcare providers. And it's just a question of kind of walking through what we know, being very clear with there are certain things that we don't know, but we are continuing to learn about and learn more about. So what I'd like to do is kind of walk through kind of where we are with our understanding of COVID, focusing, of course, on the testing and diagnostic side. I'm pretty sure everyone who's listening in kind of has heard about the importance of testing, the importance of diagnosis, not just for the individual patient, but because this is an infectious disease, also for contact tracing, preventing transmission, and trying to get this pandemic under control. So I'll walk through kind of what we know about COVID now, how we test for it, kind of where we are with things on the horizon like treatments and vaccines, and kind of hopefully where we would like to be as we try to bring this thing under control, and help individuals who are trying to take better care of themselves, and also to understand what's happening with COVID. So today on August 26th, I can kind of tell you where we are right now. I will start off with saying I expect in a week or 2 weeks, there will be at least 100 pieces of information that come out as we learn more about it. And in a way, that's a good thing. We want to move as quickly with this disease as we can, and pretty much a lion's share of the resources of this country and others are focused on trying to understand more about this. So with that, I'll start off with just talking kind of around how COVID-19 and what's specifically important to it for diabetics. I'm not only going to focus on that because I do think it's important for diabetics to understand the disease in general, but also kind of understand some of the special risks that come with diabetes. So as you're all aware at this point, COVID-19 is a worldwide pandemic. It's caused by a novel coronavirus. That's a type of virus. At this point, it has caused hundreds of thousands of deaths globally that we know of, right? So not all deaths will be necessarily associated with COVID, even if they are COVID. We do, pretty good tracking here, and in other places it may be a little bit less rigorous. And it's had a major impact on everyone's lives. It's had a major impact on the economies. It's had a major impact on healthcare just generally outside of COVID in terms of scheduling surgeries, how healthcare providers take care of their patients via telemedicine a lot more now than has ever been imagined just a couple months ago. Patients with diabetes are at risk for more severe illness than the general population. So the major additional risk factors from COVID, and I want to stress here, no one is immune to COVID. There's no one that can walk around with like an immunity shield and say, nothing can ever happen to me. But there are certain populations which we know are at higher risk, strongly associated with increasing age and also with comorbidities, right? So cardiovascular disease, but diabetes is definitely one of those. And so it's a really important disease for diabetics to know about, especially even though it's something that the entire population is impacted by. And COVID-19 can cause diabetes-related illnesses to occur. One of those is diabetic ketoacidosis. So as we're learning more about this virus, we're understanding how systemic it is. It's not necessarily something that only impacts what we tend to associate with respiratory viruses, the lungs, the upper respiratory tract. But we're finding that over time that it does impact other organs. It causes severe inflammation, and severe inflammation, of course, can exacerbate diabetes and the complications associated with diabetes. So just a little bit about what coronaviruses are. They've been around for a while now. They infect humans and animals of various kinds, and they've been causing disease in humans and animals for some time. So the common cold is caused by coronaviruses. You probably remember hearing about SARS. You can call it SARS-1 now, but it's just basically SARS, the first outbreak. It's a different virus related to the one that's causing COVID-19. MERS is another type of coronavirus, but this is a different animal. And at the end of 2019, this novel coronavirus caused an outbreak in the Hubei province of China. As you're aware, it was monitored for some time. We were unsure of how different is it from other viruses? Is it a super spreader? What kind of mortality does it cause? But very quickly it became understood that this is a completely different virus than what we've seen in the past. It rapidly spread through China and then the world. And the name was given to it of COVID-19 in February 2020. In March, the WHO then also declared that it was a global pandemic. The virus that causes the disease is called SARS-CoV-2, so SARS coronavirus 2. Previously it was called 2000 novel coronavirus, so you may hear that terminology thrown around a little bit, but it's the same thing, just the nomenclature was officially changed to SARS-CoV-2, and that's now what the virus is called. So this particular virus is related to the SARS virus and more distantly to MERS. They both caused outbreaks, but those were much more limited in scale. They stayed generally within the region at which they started. They did have a higher mortality than SARS-CoV-2 has shown, somewhere between 10 to 30%, depending on which one you're talking about. So in a way, this is less deadly per patient infected from the data we have so far. However, as we know, the major difference is it spreads much, much easier. And so with a different scale of people infected, it's become a much bigger problem. Bats are likely the primary source. So this is something that came from animals, and that's kind of where this type of coronavirus generally lives. But that doesn't mean it came straight from bats and went to humans. There may well have been another animal or infected in between, and then humans got infected from there. There's also, I'm sure you've heard the news reports of various other potential sources. That's kind of speculative at this point, but that's kind of where we know the original source was, and where it actually started is something that's still being looked into. It is an RNA virus, so some of you may be familiar, humans have nucleic acid as well, and that's kind of the genetic material that codes for who we are, and DNA is kind of the coding sequence for humans, but from DNA we produce RNA, and RNA is what produces proteins. Viruses don't always have DNA, they do have nucleic acid, and this particular one has RNA as its encoder. And so the reason it's important is because when I start talking about testing, one of the most commonly used tests that is what's going to be used to diagnose you, basically is trying to find that viral RNA, right? So it's basically a swab, and then when it comes to the laboratory, we look for that RNA to see if we can find it, and that's what detects whether you've had infection with COVID or not. It is important that diagnostic tests are able to differentiate between the virus that causes COVID-19, SARS-CoV-2, from the other coronaviruses. So the population is widely has been infected at some point or another with common cold. Especially when you're looking for antibodies, etc., it's important that test be specific for the virus that you're looking for, and not just for coronaviruses in general. So transmission at this point, there's globally over 20 million cases that have been confirmed to have been infected. We expect that number is much larger. There's a combination of people who would have been asymptomatic, maybe they were pre-symptomatic or mildly symptomatic, or maybe they just didn't get tested. And finally, maybe they got tested, but it really wasn't kept in the reporting system where we can then kind of aggregate the data and say, oh, here's everybody that's ever had COVID. So when you see these numbers not always matching up, being somewhat different from country to country, from one report to another, I think they're all, at this point, actually pretty good reports, but it just depends on what you're counting as a COVID case, how you're counting that COVID case, and different countries are better or worse at counting who's actually been infected with COVID, and testing capacity is at different places in different countries, right? Even here, we've been struggling with that for some time, even though we're in a much better place now than we were a few months ago. The main source of transmission is direct person-to-person transmission. It's not the only way of transmitting it, but that's That's pretty much what the majority of transmission is going to occur with. It's generally thought to occur with close range because you're talking about respiratory droplets. So usually less than 6 feet. And if someone coughs, sneezes, is talking, that's generally how we expect the majority of transmission to occur. There's still, again, so I'm going to say this a couple times during the talk. There's a lot we're still learning about COVID. We know a lot at this point, but even the things that we know, we always like to say, there's more to learn, and we perfect our knowledge of this disease as we go along, and we continue to gather data, treat patients, understand more about this disease. But that's kind of where the majority of transmission is occurring. It also is, in all likelihood, occurring from touching contaminated surfaces, which is why you get the guidance that avoid touching what we call the mucosal surfaces, right? The mouth, the nose, the eyes. So if you touch something which has COVID on it, and then you touch your eyes, nose, or mouth, you could potentially be infecting yourself. This is less commonly occurring than direct person-to-person transmission, but it can occur, which is why the guidances are out there to disinfect surfaces that are frequently touched, as you kind of try and avoid getting the disease. There are a lot of clinical signs and symptoms this list has gotten a lot longer than when we started. There are probably 30 to 40% of infected cases which don't show symptoms. So they're either asymptomatic or mildly symptomatic, maybe never even go see a doctor. Symptoms generally appear somewhere between 2 to 14 days after you're exposed. These are ranges, so it's not like if you're at day 15, you can't get a symptom, but most of them will appear in that date range. And a lot of these are common symptoms that you're going to get with respiratory illnesses, right? So fever, chills, cough, shortness of breath, fatigue. There's some, muscle or body aches, headaches. A lot of people have said they lose sense of taste or smell, but sore throat, congestion, or runny nose are also relatively common. Nausea or vomiting, and diarrhea. So I think something that pretty much everyone can see from looking at this list is it's not necessarily going to be easy just from symptoms to say this person has the flu or this person has COVID-19. And that's why diagnostic testing is so essential to make that differentiation as we move into the flu season coming up, right? So it's something that people are looking at very closely right now to be able to make sure that as the number of flu cases goes up, we have the ability and the capacity to do the testing to differentiate those two, because many cases are going to come in and it's going to be very difficult in many cases to differentiate one from the other. That's not to say that there aren't clinical findings that your physician is going to use. What I always like to tell everyone, and sometimes I tell physicians as well as patients, testing is a key critical tool, but diagnosis is the art of medicine. And people will get a diagnostic test. They have to consider where have you been? Have you traveled to an area? What's the prevalence in the area you're in? Have you had a history of exposure? How long ago did your symptoms start? So, even based on where you are in the disease, it may impact what kind of tests to do on you, because these tests aren't the same depending on whether you're 1 day out from exposure or you're 15 days out from exposure, right? Different tests may be more appropriate or not appropriate to use depending on where you are in the illness. So as a laboratorian, I believe in, and I know the importance of testing, but at the end of the day, it's very important to lean on your physician and discuss with your physician, the overall picture for you. So some signs to seek emergency medical attention. These are when you really start to worry is when someone starts to become hypoxic, when the oxygen level starts to go down, and these are some of the signs that if you're at home, you have trouble breathing, persistent pain or pressure in the chest, new confusion, inability to wake or stay awake, bluish lips or face, that you're reaching an emergent condition and you should immediately seek medical attention. That's not to say that these are the only signs and symptoms that can lead to you needing to call for emergency care. It's very important with COVID, especially if you're someone with diabetes or of older age, to not necessarily wait around. If you're concerned about your symptoms, you should immediately call your medical provider, especially if you're at higher risk. So some of the differences between flu and COVID-19, both are contagious respiratory illnesses. As we've shown, many of the clinical signs and symptoms are very similar between the two. So it can be hard to differentiate clinically. COVID-19 is more contagious than the flu. It also has more super spreading events, so meaning in certain areas where all of a sudden it spreads very, very quickly. So, you guys may have heard those numbers tossed around, the R0 number, basically kind of how many people get infected from everyone that's infected. That's generally higher for COVID than it is for flu. And with flu, at this point, we do have established antivirals and we have established vaccines. They're not perfect like anything, and with flu, because of the way it changes every year, certain things need to change with it. But there are established therapies and vaccines and protocols for giving vaccines and who should especially get vaccinated and not in place for flu. And that's something that's very much in development for COVID. We have made some progress on the therapy side, especially for severely ill patients. It's still, I wouldn't say fully established, but we found that we're better at managing it now than we were when it started. But there's still a lot of work to be done on the therapy side. And on the vaccination side, it's been very publicly out there, but this is probably one of the fastest vaccine development cycles ever seen. But at the same time, vaccines do take time to develop, do the trials on, ensure their safety and efficacy, and then, finally get out to making enough doses for the kind of vaccination that we're going to want to do for this disease. And that's going to be as widespread as possible is going to be the target. So there's a ways to go for COVID, but progress definitely being made. So what are the risks for diabetics? So it can cause severe illness in healthy individuals of any age. I do want to start with that because sometimes when we rightly focus on making sure that those populations that are most at risk fully understand what their risk is, sometimes their family members and others feel like it's not an issue for them. COVID is a disease that can impact anybody, but definitely it disproportionately will have a more severe impact on older individuals and people with comorbidities than someone who's a 25-year-old healthy person, right? It is different. So the risk is higher as age increases and with underlying medical conditions. Patients with type 2 diabetes are at higher risk for serious complications. They're more likely to be admitted to the ICU. If they are admitted, they're likely to stay longer and their mortality is definitely higher. So, right, again, there's a lot of data coming out. So the numbers aren't in exactly one place, but it's somewhere maybe between 2 to 4 times in terms of mortality is kind of where we seem to be settling. And it depends on how you define it as just diabetics or people with poor glycemic control. But for sure, there's a significantly higher risk, which just means that that people with diabetes just need to be more aware, be more careful. It's not about, living in fear. It's just about taking proper precautions. And there are some simple things that we do to try and minimize our risk as we kind of go forward with this. Type 1 diabetes is almost certainly has a prolonged course. The data is somewhat limited on type 1 diabetes, but generally the consensus is it also is a higher risk than someone who doesn't have type 1 diabetes. So people who are diabetic and are also obese or of older age do have an even higher risk. So it is an individualized thing to look at in terms of what your risk is. And really what you can do is, manage your activities based on that. It is still unclear if poor glycemic control causes more severe. I would say there's an expectation that it does because COVID causes so much inflammation. It's sometimes we're still teasing out is the COVID infection and the increased inflammation causes the poor glycemic control in patients who perform poorly, or is it the pre-existing poor glycemic control which led to severe COVID cases? There's again an expectation that poor glycemic control increases your risk for having more severe disease. It can cause diabetic ketoacidosis, hyperosmolar or hypoglycemic state, severe insulin resistance. So kind of the things that are complications of diabetes can definitely be exacerbated by getting COVID. So far, there isn't really evidence that diabetics are more likely to become infected. The reason it's important to know about and understand the risk of is if you do get infected, the complications are more likely and the risk is higher. So it's not so much that if you're more likely to become infected, it's that it can be a more significant event for you if you do become infected than someone who's a younger, healthy person. Prevention, so practice social distancing. This has, I think, been, I guess some people would feel it's been beaten to death, but I think you can't say it enough, especially if you're at higher risk, just take care, to the extent that it's possible as you live your daily life, to practice social distancing, do diligent hand washing after you've touched a surface that may be infected or come in contact with people. At least 20 seconds, cover coughs and sneezes so that you're not potentially spreading the virus, avoid touching your face to the extent that that's feasible. Certainly avoid the mouth, nose, and eyes. If you're indoors, try and keep good ventilation where you are. Wear masks in public settings. Again, because the spread of the virus is largely by droplets, there's a very strong consensus amongst the medical community that masks do help. Data, of course, is continually being gathered, but based on how we expect transmission to occur and what we're seeing in a lot of data sources, masks are helping. And especially when you're around others that don't live in your household, and especially if you can't keep social distancing, we really encourage that you wear a mask and disinfect frequently touched surfaces. So getting to testing, there are different tests for COVID. The one that is going to be used if you're coming in sick and your doctor wants to diagnose you is going to be what we call real-time reverse transcriptase PCR, real-time RT-PCR, right? So it's a polymerase chain reaction. It basically is trying to measure the RNA that is a component of the virus. And what it does is, I'm sure you're all familiar at this point with the swabbing. I do want to say, the established method for swabbing is what we call the nasopharyngeal swab. And it's basically that long swab that goes up your nose all the way to the back. And it is still probably the preferred method. But I think it's important to let everyone know, as we've gone through COVID and as this has become, an increasingly important public health emergency, all the government authorities, the FDA has been very good with trying to maximize the ability to get testing. A lot of data from various foundations and medical bodies have looked at just swabbing at the bottom of the nose, swabbing in the middle of the nose, and the data shows that it's very close to, if not almost as good as, nasopharyngeal swabbing. And certainly for to get people to do the testing, to cause less discomfort, that is something that is increasingly commonly being used. So if you're afraid of going in and it's necessarily going to be that swab you've all heard about, it doesn't have to be. Right now, if you are sick, if your doctor, if you're going in a setting where it's really you're at a higher risk and the doctor really wants to know, he's likely going to do the nasopharyngeal because it is still the preferred method of swabbing. But that is kind of the most sensitive way that we have to diagnose the disease. And what we do is we get the swab back in what we call transport media, and then we put it on a machine and it amplifies. So if there is viral RNA in there, we basically run it through our instruments, and that RNA gets copied over and over and over until it's detectable and we can measure it. And so if you get a test result back for PCR testing that's positive, it means that viral RNA was found in the swab that was taken from you. There are many alternative types that now are coming out. So some, it's a little bit newer, but saliva testing is also coming out now. It's still somewhat, we're trying to figure out how sensitive it is compared to swabbing, the nose. But it is out there, and people are looking heavily into home collection. Again, we're trying to get a handle on making it as easy to get tested as possible in as many ways as possible. We know the importance of diagnosing people widely and also quickly, and as geographically spread out as possible, so that we can, one, get them help, but also, isolate and prevent this from getting transmitted to other people and get a control on the pandemic itself, which we are, I think, hopefully turning a corner as we continue to get better at this. So PCR tests are very specific, meaning a positive is very likely is a true positive. You probably have heard this now because testing has been in the news a lot. Tests aren't perfect, just like anything in life or clinical medicine is not perfect, right? We have test results of what are called false positives, meaning the result came back positive, but the person may not have been infected, or a false negative, meaning it came back negative, but the person was infected. PCR testing, because of the way it's looking for a very specific sequence on that RNA, generally a positive result means that the person was infected. Now, what we're finding in the last couple months is some people tested positive, they were released, and then maybe 2-3 months later, they got a PCR test and it came back positive again. So far, the data says that's not necessarily meaning that they have infectious virus, but that's really something a clinician obviously has to look at. But in terms of if it's positive, have you ever been infected? Was there an RNA in there? It's very likely that it was. It's also got good sensitivity, meaning it's likely to be positive if you do have the infection, but there are some false negatives that come out even with PCR testing, which is the best test out there. Just because, it depends on how the swab was taken, it depends on where the swab was taken from. But overall, this is an extremely good test. It's very good sensitivity and specificity, and it is what healthcare providers are going to use to make a diagnosis because it's detectable in the time period when you want to be able to manage that patient, right? So some tests may turn out to be positive 15 days later, 20 days later, and they tell you something else, and they may have other uses, but they're not going to help you manage a patient. But PCR testing tends to be positive relatively early after exposure. So that's what you want to get, and you want to get it back quickly so that you can then manage the patient knowing that he has COVID or not. Point of care testing is something that's, of course, been around for a long time. You go into your doctor's office, you get a rapid strep test, or you get, a glucose test. Those are point of care tests. But for COVID, it's really expanded a lot because of, again, the importance of getting testing into as many places as we can. A lot of manufacturers have ramped up, and brought on board point of care tests. So far, they're good tests, but the sensitivity is still somewhat lacking in the data that's out there right now. I know these companies are working to improve these products all the time, but there should be an expectation that if you get a point of care test, it's not necessarily going to be as good as the test that would be run if you got the swab and it came into a high complexity laboratory like BioReference Labs, right? However, there's like with all things, it's a trade-off. And the benefit of point of care testing is you can get a result potentially within 15 minutes. Some of them take half an hour, depending on what the methodology is and what type of machine you're using. But it's pretty quick. So you can go in, you can get swabbed, it's run, and within 15 to 30 minutes, you potentially have a result right there, and your provider has a result right there. These tests cannot be as high throughput as what we're running in our laboratory, right? So we're running at this point, BioReference is running over 1 million tests a month, over 50,000 tests a day. So you cannot do that with point of care because it's pretty much one by one with, maybe some ways to increase the amount you can do at a time. So they have limited uses in that way, but I do think in the right setting, and I know the federal government is trying to get them into nursing homes, again, which are very high risk. for particular purposes. They do have value. Everyone kind of, as long as it's clear, you know, probably have lower sensitivity, and what we call the throughput, meaning the number of tests you can do at a time, is lower. But they definitely have the benefit of quick turnaround testing, and they measure viral RNA, but they also may measure viral protein, right? So the virus is made up of the nucleic acid, which is the RNA, but then it has different components such as the envelope, et cetera, and those are made up of protein. So what some of these point of care devices are looking at is the protein and trying to detect that particular protein on the virus. Antibody testing is something that's been in the news a lot. It's kind of had a kind of its ups and downs. I think we're in a better place of understanding it now than we were a couple months ago, but this is one particular space that still has a lot of information that needs to be gathered. So what you're looking for when you do COVID antibody testing, it's a blood test, right? So the PCR test is swab based. You either get it from the nose, some people still do it from the back of the throat, but it's a swab. The antibody testing is a blood draw. You then measure to see if you find antibodies specific to COVID-19. So antibodies are basically part of the body's immune response to infection. It's not the entire immune response, so I think people confuse that sometimes, and they think antibodies means that's your entire body's response. No, there's other cells that the body produces in response, but that's generally what we measure as the antibody. And there are many infections or post-vaccination where we're gonna try and measure antibodies to see if someone has immunity, but it's really important to know that that's not always the case, right? Detecting antibodies in all diseases doesn't mean that the person's necessarily immune or that they're gonna be immune 2-3 years down the road. And that's kind of why everybody's being cautious in how we handle antibody testing. But I think at this point, there's growing consensus that some kind of short-term immunity is likely present for most people who are infected with COVID. The health authorities don't yet recommend it to physicians for clinical decision-making because they don't yet know how long it lasts, who are the exceptions, things like that, which we're probably gonna gather in the next couple months, right? Does it last 3 months? Does it last a year? Does it last 2 years? And then even if antibody levels go down, is there remaining immunity? And there are some good signs from some of the data that's coming out that antibodies, at least for a couple months are there and generally tend to indicate there's some kind of immunity. And after that, there may potentially be what we call cellular immunity that remains. So if you get reinfected, it may be less severe. But I do want to really stress that that's not yet in any health authority guideline or clinical guideline. They're going to wait for more data to come out before they're going to make recommendations like that. So it's really more of a discussion to have with your clinician, where he thinks it is and what he thinks it means. But it's important that people don't take it as some kind of immunity passport where they find antibodies and now they feel like they can gather in, gatherings of 50 to 100 people. That's what we're trying to avoid, even though we have, I think, a good expectation that there is something there with antibody testing. Where it's really being used very widely in addition for that purpose is what we call serological surveys. So you may have heard about the CDC's doing them, state governments have done them, even cities and counties have done them. A lot of people don't get tested for COVID or they may be asymptomatic. So just the numbers of positive PCR tests doesn't necessarily tell you how much your population has had COVID. Serological surveys is basically looking for antibodies because antibodies tend to last longer. PCR testing is only positive for maybe up to 2, sometimes 3 weeks in most people, with some exceptions. But antibodies are expected to be higher. So even if someone's no longer sick, they've recovered, you should still be able to detect antibodies in them months out. And so that's what they're really being used for as well, to try and determine how many people in the US have been infected with COVID, how many people in the state have been infected. So if you're sick, stay home, except to get medical care, take care of yourself, get rest and stay hydrated. Always stay in touch with your doctor, try and avoid public transportation to avoid spreading, monitor your symptoms, avoid sharing personal household items, and follow healthcare instructions from your health provider and local health department. So common sense instructions, but really, really important Sometimes we take common sense instructions and just, it doesn't seem to have that kind of urgency. But there really are simple steps that really can make a huge difference to you as a patient and a patient with diabetes. And also just overall for how we manage this disease. Just doing the simple things is what we can do as individuals, right? So some of the common myths, this is just another coronavirus. I've kind of said it here that we're talking about, other coronaviruses cause common cold. So why is this any different, or is it's not different? This is clearly different, right? It's different from pretty much anything that we've seen for a long, long time. And we're seeing that as we watch this pandemic spread around the world. So it spreads more. It does have a mortality rate, maybe not as bad as SARS or MERS, but pretty bad. And it's important that we manage it overall so that we don't overwhelm our healthcare system, but also especially focus on elderly individuals and people with comorbidities, because a lot of what we've seen in the first couple months in terms of the people, the mortality, a lot of that was in that vulnerable population, and hopefully getting out the information, obviously changing protocols and how we handle it from the healthcare side and the government side, but also making sure those individuals understand that they should be more cautious than others. Droplets live on all surface for up to 24 hours. That is not true. I think the CDC at this point is saying maybe no evidence shows that it's more than 7 days, which is probably pretty fair. But there are it depends on the type of material. It depends on if it's in sunlight or not in sunlight. So don't think that if it's just 24 hours that every surface is fine. Try and be cautious. If it's something that's commonly touched, disinfect it. If I'm asymptomatic, I'm less likely to pass it on. So actually a relatively recent study came out that showed that the viral load, what we see, the amount of virus in asymptomatic people might actually be as much as it is in people who are symptomatic. So the expectation is that they can spread it just as easily as others. There are incidences where we think it was silent spreaders caused outbreaks in certain areas. So maybe, because you're not coughing and sneezing, that's a little bit of a less risk, but overall the risk is probably very similar because you're not, you're shedding about as much virus as others. And in some ways it's more dangerous because, people who are symptomatic are generally being isolated versus asymptomatic patients. It's possible for antibodies to appear if you had a bad cold. So antibodies, when we measure antibodies, we're measuring antibodies specific to the disease we want to look for. Depending on the tests and what we're able to do, they're not always perfectly specific, but the ones that have come out for COVID are actually very good tests at this point. There was, a bit of back and forth when antibody testing first came out. The FDA tightened up on that quite a bit. Obviously, as a high complexity lab, we never dabbled with that. So I think it's important to know who you're getting tested from when you get any kind of test. And certainly the FDA has cracked down on some of the practices that occurred in the beginning of antibody testing from the people that, kind of fly by night companies. Having diabetes making you more susceptible to catching COVID-19. There's no evidence yet or at this point. And the expectation that it does not actually make you more susceptible. It's really more ensuring that when you are infected, that you're properly managed and that you understand the risk if you get infected, which is why you should be cautious and take just the simple proper precautions to avoid getting infected. Having type 1 diabetes put me at lower risk. So the evidence is lower for we just don't have it, right? But there's no evidence that type 1 diabetes won't have as much risk as type 2. And some data is coming out that shows that it probably is increased risk. My sugar levels are under control, so I'm not high risk. That's also not necessarily true. Diabetics are at higher risk irrespective of glycemic control. And that data is already out there. And having pre-diabetes would be a lower risk than complications. So again, there's data out there that shows that even pre-diabetics are at higher risk than people who don't have that. We don't know yet if that risk is equivalent to someone who's diabetic or other, but definitely I wouldn't think that you shouldn't, you don't need to take precautions if you're pre-diabetic. So what's on the horizon? I've talked a lot about kind of, what we've learned so far. There are numerous studies that are ongoing for treatments and vaccines. One of the ones that has got a lot of data, there was very large studies done in the UK. It is now being used quite widely in the US. Dexamethasone, which is a generic drug, is cheap. It's been around for a while. It's basically an anti-inflammatory. It's always a steroid. It's being used in some settings for patients requiring oxygen supplementation. So we're finding that it's not used in everybody. It shouldn't be used in everybody. But people who are intubated, people who are receiving oxygen because they're deteriorating, we are tending to find that dexamethasone helps in those patients. And so it's still ongoing, kind of looking at the data, but it's relatively widely used for something that came out relatively recently in terms of using it for COVID. Antivirals are being used in a controlled fashion as we gather more data. You may have heard of, plasma therapy as well with hyperimmune plasma. That's also something that's being done in controlled settings for very severe cases with the hope that that can help, right? So that just means someone who's already got antibodies in high levels, their blood is being used to try and treat people who are severely ill, to try and, hopefully those antibodies will then, neutralize the virus for the sick people. Vaccine development is being extraordinarily heavily funded and is actually progressing very quickly for, what is usually a slower process. And several vaccines have had promising early trial data. So we go through different phases, phase 1, phase 2, phase 3, and onwards as we develop a vaccine. Several vaccines for early phase 1 data has shown promising results so far. Hopefully that continues as we go through the various phases and more manufacturers bring additional vaccines on board. I think the benefit of having that is, one, the more chances you have, the more people that are trying this, the more likely you have that some of them will succeed, and I think we're quite hopeful that they will. But also from a capacity standpoint, the more people that are manufacturing this, the more vaccines that can be produced when we do have something that can be put out there in the general population. So in summary, COVID-19 has had a severe impact on individuals and society. I think we all know that. It's especially important for diabetics and other populations at high risk to take necessary precautions. Some of those are social distancing, wearing masks, other simple measures, washing your hands can go a long way to reducing transmission. There is, I think, a lot of very hopeful signs on the horizon, both from therapy with drugs, with hyperimmune plasma, managing severely ill patients with drugs like dexamethasone, and vaccines are being developed at a breakneck speed to the extent that can be done safely and with some idea that it's going to work at the end of the day. And it's always important to maintain healthy practices and diet. I think what we found is the healthier you are, the less likely it is you're going to have severe disease. And with diabetes, of course, as you all know, you can stay healthy and manage yourself well. And that's always good for COVID and for everything else associated with it. So that's what I have. I don't know if there's time for questions.
There is time for questions. Hi, this is Janine Salente again. Thank you, Dr. Mathur, so much for this valuable information based on what's known about COVID-19 as of today, August 26th. So we do have time for question and answer. And I just wanted to start with the questions that came in during the presentation, but please use the Q&A at the bottom of your screen if you have a question to present. The first question is, there was a very recent case in Hong Kong that a patient got infected twice by different SARS-CoV-2 strains. Is it possible for BioReference Lab to keep viral strain information for positive cases so that the patients can track it if they're suspected to get a second infection?
Right. So I'm going to answer that with a couple points. One, the PCR tests that we do don't actually look for viral strain. They're measuring certain targets on the RNA. Some have 2 targets, some have 3 targets, depending on the instrument you're using, but they're not really looking and cannot tell you what the strain is. The Hong Kong case, again, shows why we're cautious about talking about immunity. There was 3 to 4 months after, and that's kind of where some data is showing that's maybe where antibodies may confer that level of immunity, and then after 3 to 4 months, it seems to go down. Again, this is very, very early and not something I would say that's in clinical guidelines at this point. But I think that something that gets missed a lot is when the reinfection occurred, it wasn't a severe case, right? It was actually a very mild case. And immunity doesn't only mean you won't ever get reinfected, right? And that's not even necessarily how vaccines work, right? As we all know with the flu, it may well be that you can get reinfected, but hopefully, because your body has that, that memory, which is how it works, that second infection will be mild. So there's a lot still to know about that particular case, but I think it highlights an important point. One, we don't make assumptions about immunity until we have a lot of data to back that up. But also again, the flip side of it is, there's been 20 million plus cases, not a lot of cases of reinfection. This case, I think, is important to look at, but sometimes with this disease, like with all emergencies, the latest data is kind of what drives a lot of discussion. And it's just one data point out of, at this point, what is a wealth of information. So we're going to learn a lot more as we move away from that time window of 3 to 4 months and see, do more people get infected? When they get reinfected, is it always with a different strain? Viruses mutate, right? Not all mutations are meaningful. Most mutations are not meaningful. There are only certain mutations in a virus that can significantly change how it behaves and if that behavior is relevant. So does it become more infectious? Does it become more severe? We haven't really seen that for COVID in terms of severity of illness. And we don't really have data, especially not from one case, that says, okay, you may only be immune to the strain you are infected with, you're not going to be immune to any other strain, right? That's not yet something that's known. So that's kind of the general behind it, but definitely not from PCR testing. You're not going to be able to do that. You have to do a different kind of sequencing of that RNA to get the strain and other information about the virus.
Thank you very much. We have about 7 or 8 questions. And the next one that came in is, do you think there will be at-home quick testing in the near future, or will they have it at schools or any other facilities?
So I think that's already starting to happen. I don't think at home you can get the result, if that's what you mean, but at-home kitting, where you can, self-collect the swab. That's another reason why it was so important that we move away from, even though it's still the preferred method in a healthcare setting where someone's coming in sick, but we move away from, the nasopharyngeal or the deep nose swab to lower nose or middle nose swabbing, because that can be done by the patient themselves, right? So it's still, I think, well regulated by the FDA. They're controlling, who can do that, because you want to make sure as you increase access that you don't, create a situation where the testing just becomes useless. So I do think, though, it is ongoing, where we are seeing that spread, where people are offering the ability to test at home, swab yourself at home and then send it in. It's still pretty limited because there's a lot of options where you can, drive-throughs, retail settings like the various chains that offer it. So there's a lot of ways to get it now, but at-home kitting is one. Schools and universities definitely have many programs that they're setting up. They may partner with a laboratory like us to test their students. They may have other programs in place. For an institution like a school and employer, it's not just about the testing. The testing is a key component, but it's also about social distancing, managing isolation of patients that come back positive, right? Contact tracing. So there's a lot that goes into how schools and employers manage COVID. But from a testing perspective, definitely BioReference has partnered with many different organizations of all kinds, right? From employers to schools to sports to you name it, right? To help them with their testing needs. And it's unique. It's unique for every type of institution, depending on what their needs are. And how they want to manage COVID overall.
Thank you. The next question is that was posed is HA1C levels versus COVID?
Mm-hmm. Yeah, so the data shows that, controlling that better is more likely to have less risk. I don't know that. I think there was a paper that came out relatively recently showing that is associated. I think What I'm trying to present here, especially because I'm talking to a general audience, is stuff that's well established. I do think most physicians would take that into account. But I think for general audience, I think I want to make the point that one of the advantages of the amount of studies that are coming out now is we're learning at a very rapid pace. I think the thing we have to be cautious with, a lot of this data is still not peer reviewed, may have just come out in a small publication or a small number of studies or small number of patients. And so that just all has to be taken into account when making decisions about management and what impact each of these may have.
Okay, so we have a few questions about care. I am unable to drive. I'm 68 and I have type 1 diabetes. How safe is it using an Uber even if the driver is wearing a mask?
I think that's getting a little bit into clinical care, which from a laboratory side, we don't generally tend to give a lot of advice about. Okay. I would probably pose that question, and to expand on that a little bit, it's probably going to depend on your individual situation. What are your other risks? What other options you have to get testing or to get care? So it's really a question, and an important question, because it's a very fair question, to discuss with your physician, who will have that information about, you know, your particular case, your particular situation, your risk, and what options are available to you that are alternatives to doing that.
Okay, thank you. The next question is, exactly what are the biological complications for someone with type 2 diabetes? What does the virus attack?
So the virus is not, even though it is systemic and we found that it can cause damage to various organs, it's really obviously a respiratory illness. There is some evidence that it can impact, you know, organs that will impact diabetes. The major, like all infections, it's the inflammation, which COVID is very heavily associated with, which exacerbate the complications of diabetes, right? And so the cytokine storm that you've heard about with COVID is one example, but it's generally a disease associated with inflammation, and inflammation in diabetics can cause flare-up of the disease, right? And so that's more how I would think of it than something that's, you know, it's not that's targeted at the pancreas or something like that. It's more just the way this virus behaves and its association with inflammatory states that causes significant problems in diabetics.
Thank you. So we have time for one more question. And for those who do not get their questions answered, please know that we will contact you after this to answer those. So the last question for today is, I have type 2 diabetes and I'm deathly afraid of getting the virus. How can I relieve my fears?
So that's a really good question, and I don't think you're alone. And honestly, I don't even think it's for diabetics. I think we're all in the last couple months trying to figure out how to manage getting used to this new normal of COVID being around. I would say, you know, we can't be fearful because the virus is likely to have some longevity in terms of staying around for a bit. We have to manage it like we manage all risk, right? So if you're a diabetic, you're already managing risk, and you've learned how to manage that risk with your physician, with your family, and just the personal care you take. And this is a new normal until, you know, significant advances have been made in therapy and vaccinations on how to manage risk. So you take the simple steps that, you know, healthcare authorities and your physician and your community, you know, are talking about, but do it in a way that's, you know, that balances just living your life and minimizing your risk. So, you know, keeping appropriate social distancing, wearing a mask, not taking unnecessary risks. But I don't think stopping from doing anything. I think you just manage it like you manage any other risk. And I honestly think people with chronic diseases like diabetes have learned to do that sometimes better than people who don't.
Thank you very much. And I just want to close today by thank everyone again for joining us. The Diabetes Foundation, our webinar series, we focus really on what you need to know when managing diabetes. And our next webinar is being presented by Medicare. It'll be in September, and they're going to provide an overview of all the different parts of Medicare so you can choose your plans to your benefit. Please look at our website, www.diabetesfoundationinc.org, for more programming information, and of course to sign up for our weekly email, which references events such as these. I just want to really a special thank you to Dr. Mohit Mathur and Nina Kardasha for helping us present this amazing webinar today. Thank you all for participating. Thank you for your questions. Please see more about BioReference at www.bioreference.com. Thank you again, everyone, for coming. We hope you have a nice day and stay safe.